radiologist in Max Hospital, Saket, New Delhi. I would be talking on the uh, Doppler of the arteriovenous fistula, pre-fistula creation and post-fistula complication assessment. And so that's why I have kept the name as choosing the right path, Doppler ultrasound of hemodialysis fistula. This was a news recently in the newspaper. This very well says the disease burden of dialysis in India, where the government is also thinking of putting up various dialysis centers throughout the country. So we will be discussing the pre-operative planning of dialysis assessment as well as the post-operative assessment of the dialysis access. In pre-operative planning, we need to have the prior knowledge of the surgical technique, what needs to be done. The significance of not being dominant is we need to see which hand is dominant and which is non-dominant, so that the fistula can be created a non-dominant hand for future easy accessibility. Doppler parameters must be accurately assessed to ensure arterial inflow. A suitable vein for either fistula or graft should be accessed, and we should rule out central vein stenosis or thrombosis. We should know what the different types of AV fistulas are, where the different types of AV grafts, the clinical indications for ultrasound, normal ultrasound appearance of the AV fistula or the graft, the ultrasound evaluation of fistula maturation, and complications which are associated with the fistula. Coming to each of them individually, what are the different types of fistula which have been created in case of hemodialysis? One is the direct fistula, which is basically the radiocephalic or the end-to-end fistula is being created. Transposition fistula, where one end of the fistula gets the venous component goes and attaches to the side of the artery. There are different types of grafts. One is called as loop graft, where a graft is placed between the artery, communicating the artery and the vein. The straight graft, which is basically in the upper arm, there is the brachiocephalic, which uh, the graft is put between the brachial artery and the cephalic vein. There is another called as the hero graft between the brachial artery and the right atrium. The order of preference for the vascular access is the first is the radiocephalic fistula in the forearm. If that doesn't work, then there is a brachiocephalic fistula. Then in the decreasing order is the brachiobasilic and the arteriovenous graft. How do we assess the artery? So the internal transverse luminal diameter of the artery should be measured. If the radial artery at the site of fistula should be more than 2 mm, and the brachial artery at the antecubital fossa should be more than 4 mm. The presence of calcification should be recorded where our calcification is there, so that the fistula creation at that point should be avoided. Arterial spectral waveform should be assessed to screen for inflow and outflow diseases. The RI of the resistive index should be less than 0.7 after the first release. That is, whenever we put a tourniquet and release the tourniquet, it should be less than 0.7. High radial artery takeoff is generally seen in 5 to 10% of the cases. We should be aware of this anatomical variation. And modified duplex Allen test for the patency of the deep palmar arch should be done. Venous assessment is done with internal jugular vein, subclavian vein to assess the permeability. Mapping vein should be measured after it is dilated by tourniquet or putting the hand in a dependent position. The internal diameter of the vein should be measured in caudal, mid, and cranial forearm at the antecubital fossa, at the caudal, mid, and cranial upper arm as applicable. It should be more than 2 mm for AV fistula and more than 4 mm for the graft. The basilic vein of adequate size is called when it is more than 4 cm in length, caudal to the antecubital fossa. The depth from the skin surface to the cephalic veins for a subsequent superficial this procedure needs to be assessed. Upper arm cephalic vein is too small or thrombosed, that needs to be told. Sclerotic or thick-walled vein noted, that should be mentioned. And large branches of the vein near the site of the fistula can result in non-maturation of the fistula. So all these points needs to be mentioned in the reporting. So coming to the assessment, so the IJV should be easily compressed and spectral waveform must show cardiac and respiratory variation when you put in the IJV. So this is the interjugular vein where you are able to see the nice flow. For assessment of the central or venous stenosis, you need to see that there is no thrombosis or there is no loss of compression. and the normal flow should be there on the intrajugular vein. In case of if there is bilateral changes which are found in the internal jugular vein, such as the thrombosis and reversal of the flow, then we should think that there is a central venous thrombosis in the superior vena cava. If the return vein should be more than 2 mm, as I told, superficial and must not be thick, they should not have a thick tributaries. So is appropriate. When the veins are deeper, thin, and with many branches, they are not suitable for the fistula creation. So if the bilateral changes, they do confirm the interjugular vein thrombosis. Now, when we are assessing the brachial artery, it should be more than 4 mm, and access for appropriate feeding artery caliber should be seen. A radial artery should be more than 2 mm. So this is a good caliber with a good flow with a PSV of 50. RI is less than 7, and this is a good artery for the access. If the brachial artery diameter is more than 4 mm and the radial artery 2 mm, but the thin caliber and the PSV is less than 50 with high RI, this is not a good artery for the access. Pre-surgical mapping should be done for the IJV and subclavian stenosis to assess possible of that side, change side of resolve. Radial artery is not suitable, then check brachial. If superficial vein, then look for cephalic vein first and then basilar vein. If no superficial vein is suitable, then deep vein more than 4 mm for the graft should be considered. This is normal ultrasound Doppler appearance of the AV graft, where you are able to see uniform draining vein in the gray scale, and on Doppler you are able to see a low resistance waveform with the peak systolic velocity. If you see, it is around 100 to 400 centimeter. Flow rate is 600. How do we calculate the flow rate? So flow rate is calculated by access flow in the determined equipment, and within the equipment you will get this formula. So that is the transarterial velocity and the cross-sectional area into 60. That becomes the flow volume. If the flow volume is less than 300 ml per minute, then access dysfunction with recirculation failure can happen. And in case of the graft, it is less than 650 ml per minute, then steadily increasing relative risk of thrombosis can be thought of. What are the different clinical indications for evaluation of AV graft? Abnormalities on examination should be absent of weak palpable thrill, distal limb ischemia, clinical signs of infection, perigraft mass, and poor fistula maturation. Abnormalities during the dialysis will be difficult cannulation, thrombus aspiration, elevated venous pressure, which will be more than 200 millimeters per of mercury, elevated recirculation time more than 15%, and low area urea reduction rate, that is less than 60%. To assess the maturation, how long do the fistula typically require for maturity is basically 6 to 12 weeks. When should an ultrasound be obtained to assess for the maturation? If the fistula does not begin to demonstrate clinical signs of maturation by 6 weeks, you should do an ultrasound to see what the abnormality is there. What ultrasound features predict the future fistula maturity? That is by KDO-QI of rule of 6, when the venous diameter is more than 6, vessel of to skin depth is less than 6, and fistula flow rate is more than 600 ml per minute. The clinical signs of AV fistula maturation are tabulated here, and this has been taken from the renowned article where they have done this study. This palpable thrill throughout the entire draining vein that easily compresses, loss of thrill, low pitch buoy, reserved diastolic flow, visible draining vein that's straight and sufficiently superficial for cannulation, and visible draining vein that is more than 10 centimeter in length. These are the images of normal maturation, where you are seeing the feeding arteries, normal spectral flow, the anastomosis is clearly seen, normal spectral waveform of the fistula is seen, the draining vein has normal flow volume, and the distal arteries normal flow velocity and spectral waveform is seen. So there are some of the precautionary or red alerts, which signs which we can see is the changes in the arterial flow appear as early as 24 hours after surgery. If this is not seen, then this is a red alert. A native AV fistula is mature in 1 month, and 80% of failures in development happen in the first month. So we should be aware of these things. The complications post fistula creation are failure to mature, stenosis, thrombosis, aneurysm, pseudoaneurysm, Steele syndrome, collateralization, and infection. We'll see the individual examples. Early thrombosis happens because of technical error, external compression for hemostasis, hypotension, dehydration, or early puncture of an immature vein. Late thrombosis can happen because of secondary to hypertension, dehydration, compression, trauma, or acquired stenosis or runoff vessels. When delayed, early IR procedure can help salvage AV fistula graft. In the area of anastomosis or draining vein, there should be thrombosis when that can be assessed. The risk of thrombosis increases with degree of stenosis. So, if the significant stenosis is when there is more than 50%. This is an example of occluded radiocephalic fistula. You see there is a slow flow or there is loss of flow in some of the areas within the lumen, and on cross this short axis we are able to see that there is a pectoral thrombosis. Again, this is an example of a thrombosed return vein where you are able to see in the gray scale there is ecogenic content within the lumen, and then even in the power Doppler you are able to see the reversal of the flow. In case of thrombosed graft, this is an example of a graft where you can see there is a thrombosis within the graft is seen. Stenosis is usually occur at the vein near the anastomosis. A hemodialysis fistula or prosthetic graft has a Doppler waveform that resembles artery with a systolic velocity of 100 to 400 cm per second. Higher velocities more than 400 indicate the presence of stenosis. A monthly decline in flow by 20 to 25% in the follow-up ultrasound is significant. So this is the famous Internal Journal of Nephrology where they have classified severe stenosis as the ratio of PSV at stenosis at 2 cm beyond the anastomosis if normal appearing more than 3. That is the velocity, and image characteristic is intraluminal echogenicity less than 2 mm lumen and more than 50% diameter reduction, and there is marked reduction in the lumen diameter with color Doppler. This is in the case of example of stenosis where you are able to see there is low flow with narrowing of the diameter. Similarly, there is long segment narrowing of the diameter of the artery. The pitfall is AV fistular stenosis with mildly elevated velocities that can resemble as there is a stenosis. Another pitfall is marked elevated velocity without stenosis. In such case, you are able to see that the velocity is increased, but there is no stenosis. Aneurysms happen in case the draining vein due to pituitary puncture. Hematoma is formed due to needle puncture, and micropseudoaneurysms which are less than 5 mm diameter, or macropseudoaneurysms which are more than 5 mm diameter. Pseudoaneurysms are both in venous and arterial ends, usually due to infection. Venous aneurysm and thrombosis example is you are able to see a large aneurysmal dilatation of the vein, and there is also thrombosis within the dilated vein. Pseudoaneurysm happens along the wall where you are able to see the aneurysmal dilatation of the venous wall, and this is a pseudoaneurysm with some peripheral calcification, peripheral thrombosis. There can be multiple pseudoaneurysms in case of the graft. This is a graph where you are able to see the different aneurysms. There is a very important phenomenon called Steele syndrome, where there is reduced blood flow through the arterial system due to arterial occlusive disease causal to the anastomosis. And this may arise from excessive blood flow through the draining vein in addition to reduced collateral perfusion. The incidence is higher in case of diabetic and elderly. So this is an example where 2 months post the creation, the flow is like that, and where it is normal, and 5 months post creation, there is reversal of the flow, and where in the arterial superficial anastomosis, there is normal flow. So this is the case of a Steele syndrome. There can be collateral vessels which can develop, as you are able to see, there are small vessels which have developed because of the stenosis or thrombosis around the graft. Infection can happen in 20% of fistulas, and localized infection occur at the site of the puncture, and this can last for 4 to 6 weeks. And due to surgical contamination, also it can happen extended superficial infection and bacteremia seeding. So this is a case example where there is this soft tissue thickening which is seen around the fistula. So this is a case of infection, and in scintigraphy you are able to see the increase of ache which is seen in the arm at the site of the fistula occlusion. So whenever we do a pre-procedural assessment, we need to give a detailed analysis of what the anatomy of the vessels are. So the best is to draw a hand drawn diagram to assess, to evaluate, to indicate what all things you have evaluated, and anatomically where the division is. If there is a high branching, there are multiple tributaries, what the diameters are. So it should be the report should also accompany by the diagram. So this makes sense, and it is also helpful for the clinician to decide on what the site of fistula to be created. So, before we conclude, I would like to emphasize that the vascular access must be established promptly, and nave AV fistula should be the first choice. A multidisciplinary team must be assembled in order to define the best access. Every patient should have a detailed color Doppler ultrasound map done before any attempt to establish vascular access, and a color Doppler ultrasound should be performed promptly when a complication is suspected. I would thank the AIUM practice guidelines, International Journal of Nephrology Dialysis Transplant, Radio Society of North America, and also the Max Hospital nephrology team by which I'm working with and I'm learning and day-to-day practice. And also, I would give the reference of the Times of India where the article was published on the dialysis unit to be established in India. Thank you.